Welcome to the labor and delivery and postpartum portion of your OBGYN clerkship. This will be a fast-paced 1 to 2 weeks, and we have put this together to give you the tools you will need for success and to learn as much as possible. We will discuss postpartum rounding on the mother-baby unit, as well as touch on some components of labor and delivery. On mother-baby unit, or MBU for short, we will have you see 1 to 3 patients daily. We typically have you start with 1 patient and increase by the end of the week to 3. If possible, we ask that you see patients that you have followed downstairs on labor and delivery. Taking a history on a postpartum patient has some unique aspects. For each patient, we ask about their vaginal bleeding, spontaneous voids, and if they are tolerating food and liquids by mouth. Let's break each one of these down. Regarding vaginal bleeding, it is normal to have bleeding, and this can in fact be worse while breastfeeding. First-time moms can find this scary sometimes. We tell patients that if they are soaking through more than a pad an hour for several hours in a row, that is when they should be concerned. Otherwise, the remainder are normal variants. We ask each patient if their pain is well controlled and if they are eating and drinking normally without nausea and vomiting. We also ask patients if they are peeing without difficulty. For patients who have had a C-section, they typically keep their Foley catheter in until the next day, typically less than 24 hours since delivery. For patients who have had catheters, once they are removed, they have up to 6 hours to void spontaneously. For patients who have had a C-section, we also ask them if they have passed gas. On to the exam. The main components of a postpartum examination are an abdominal and lower extremity exam. On the abdomen, examine for fundal height and tenderness. Patients should be what we call appropriately tender, i.e., it may be uncomfortable for someone to press on their abdomen, but they should not be jumping off of the bed. I find it helpful to ask if they are having pain like a sore muscle that has worked too hard, and that often helps with differentiating normal postpartum discomfort with pathologic pain. Fundal height will vary. Especially on postpartum day 1, the fundus may be at, below, or even above the umbilicus. The most important thing is that it is firm and not exquisitely tender. We also examine for lower extremity edema and calf tenderness, given the increased propensity for thromboembolism in the postpartum period. Many women will have lower extremity swelling. Ensure that it is equal. You can advise them that this is often normal, and may even become worse on days 3 through 5. The best thing that they can do is ambulate and elevate their legs while in bed. They can even wear TED hose if they would like. If patients have had a C-section, then be sure to examine their incision. If they have a bandage on, just take a look at the bandage and make sure that it is clean and dry. It can be removed 24 hours post-operatively, but check in with your resident before doing so. For the patients that you see in the morning, you will write a postpartum note. It can be found in Meditech under the heading OB Postpartum Note. Clearly document in your note that this is a medical student note for billing purposes. These notes can be co-signed to the intern that you are working with. Try your best to not copy and paste the resident plan. We understand that many of our patients are complicated, so try to write your note and then compare it with ours for accuracy. When you present to the attending, you will start with your one-liner. This will sound something like, 22-year-old G1 P0, postpartum day 0 from a term spontaneous vaginal delivery, complicated by preeclampsia with severe features. We do not change the G's and P's in the immediate postpartum period. Give a full presentation as you would for any patient, including subjective, objective, assessment, and plan. Regarding the subjective and exam portion, please include items that we have talked about previously in this presentation, such as fundal height. Labs that we are most interested in are the hemoglobin prior to their delivery and after, as well as the estimated blood loss. Medical problems specific to the postpartum period include things like preeclampsia and endometritis. For preeclampsia, please make sure you mention if they are on any long-acting blood pressure medications, like Procardia or labetalol, how their blood pressures have been in the last 24 hours, and if they have any symptoms like headache or visual changes. For endometritis, discuss their abdominal exam, what antibiotics they have been on, and the last time they were febrile. Conclude with your plan. Either continue routine post-operative or postpartum care, or discharge. Vaginal deliveries can go home as early as postpartum day 1, as long as the baby has been in the hospital for 24 hours. They must go home on postpartum day 2, unless medically indicated to stay. C-sections can go home as early as post-op day 2 if they are meeting their milestones. They must go home by post-op day 4, unless medically indicated. On to labor. Labor and delivery is a fun and exciting place. It can be fast-paced, so pay attention to everything that's going on around you so you don't miss anything. At the beginning of each labor shift, your resident, typically the intern, will assign 2 to 3 patients to each student. These will typically be relatively uncomplicated, laboring patients. If these are private patients, i.e., they have an attending name next to them on the board, please ask the nurses if the patient is okay with having a student participate in their care. Once established with your patients, please plan to see them about every 2 hours and write a labor note. These can be found in Meditech under the heading Labor Note. Pay attention to the board, and if you see that your patient is getting close to complete, or 10 centimeters, stick around the room so you don't miss the delivery. This is especially true with women who have had multiple vaginal deliveries, as those can go fairly quickly. After each delivery or C-section, we fill out what's called a quad sheet. This is something that you can help your resident with, and they will very much appreciate it. Vaginal deliveries are a fun part of a labor and delivery shift. Please gown and glove for each delivery that you participate in. If you are prepared in this way, then we can have you participate as much as possible. Delivery can be a fun time to participate in patient care through encouragement during pushing. Follow your resident's lead with how enthusiastic to be, as this differs from patient to patient. Although deliveries are fun and exciting, they can quickly become dangerous for both mom and baby. If this is the case, it is best to take a step back and observe, as there may be many people coming into the room and it can get confusing and hectic. After everything calms down, feel free to ask the resident what happened and debrief. If there is ever a situation that you are uncomfortable with, you are always free to take a step back and even leave the room. C-sections are another fun experience on labor and delivery. Similar rules apply here. Always grab your gloves and an extra gown for the scrub tech. Ask them if it's an okay time to hand them off so you do not risk contaminating the table. In all routine cases, we will help you know when to scrub in. Things can get crazy in the event of an emergency C-section. In this case, it is best if you get your gown and gloves open to the scrub tech when it seems like they have a moment. You may have to wait to scrub in until after the baby has been delivered. Still, stand relatively close to the table so that you can observe. Again, if you are ever feeling faint or unwell, please scrub out and sit down or even step out of the operating room. Lastly, we will touch on contraception. Contraception is an important aspect of postpartum care on the mother-baby unit. Contraception options depend on timing. Immediately after delivery, both female and male sterilization is an option. Postpartum tubal ligations can be performed on postpartum day 1 or 2. They may also be performed laparoscopically at 6 weeks postpartum. Other options are all progesterone-only containing birth control. Women in the immediate postpartum period should not utilize any birth control methods that contain estrogen due to the risk of venous thromboembolism. At their 6-week postpartum visit, we may offer them estrogen-containing options such as combined OCPs, a transdermal patch, or a vaginal ring. This concludes your introduction to postpartum care and the labor and delivery service. We hope that this will be a fun exciting, and educational experience and look forward to having you on the service. Please email your resident ahead of time if you have any further questions or concerns.